Hello, hi, welcome. I'm Sandi Drewett. I'm the Director of Workforce and OD at Moorfields Eye Hospital, and I also spent a couple of months as Deputy HR Director at Nightingale. So I'll be chairing this webinar and also offering an overview of the contextual perspectives between Nightingale and Moorfields from a wellbeing perspective. I'm also doing this for the very first time on an iPhone because I came back from leave and found that my organisation had blocked all access to Zoom. So I can't see myself and I can only see a couple of people. So I'll do my very best to chair this. So we've had introductions from everybody. So I think, first of all, thank you so much for joining us on a Tuesday lunchtime and welcome in particular to our speakers. We've got a variety of speakers from professional and organisational backgrounds who've all got very, very different experiences of providing wellbeing support to staff who've worked during the COVID pandemic. So we'll cover a whole range of things from a range of different perspectives in the 50 minutes that we have left to us. So I suppose, just a reflection, I suppose it's now 135 days since Sunday, March the 22nd, which was a key day in terms of the London pandemic emergency response. Across London on that day, leaders were at the hospitals to take part in emergency planning at 9 AM and 4 PM. And there was also a group of leaders and military in another London hospital, which were scouting out a site to be used as a military staff facility, in addition to the significant ITU capacity that all of us were being asked to identify and resource as part of the day's work. I think during that planning and also during the pandemic, the commitment and the courage of our staff has challenged us to think really differently about how we support our staff. And we all recognised that this would be crucial in how we manage the pandemic. At that time, we had teams that were watching Lombardy, were watching China, reading reports and research that was available then. And in the very early days, I think we could say they were characterised with a particular flavour of anxiety that we hadn't experienced before. So we needed to mobilise, respond and step up to support our staff at a pace that was unprecedented, and with a response that was being coordinated at different levels of the system. Individual organisations, STP, London, and also nationally. So the rest of our time will describe how parts of the system did that, how we've learned from it, and what we can take forwards. So I'll hand over to Chris Caldwell and Tavistock to start us off. Hi.
Chris, you're on mute.
Sorry, Lydia and I are going to do a double act on this because it's Lydia who has led most of the work that's happened over the last few months and knows this work intimately. So I want her to be able to share some of the experiences. But and I'm going to be really quick, but you've got a couple of slides that that summarise some of the work, and we're more than happy afterwards to talk to anybody who wants to hear more. So can we go to the next slide? Okay, great. So so NCL in mind, as it started off, it is our system-wide response across the North London partners, STP as it was when we started, ICS as it is now. And it was right at the beginning, the STP workforce programme lead started to think about the need for staff support and staff wellbeing, and commissioned the Tavistock and Portman, because of its history of working in this space, to lead a collective across North Central London to gather together all the experts, and there are many experts across our patch in workplace wellbeing and in the support of people who are likely to be experiencing a traumatic time at work or outside of work. And the NCL in mind was about connecting people, and we focused on two things. So Together in Mind, which is the website and the place where people come to access the stuff that we've put together, and we've put together a whole range of resources for people, and it's been based on what matters, actually, underpinned by a survey which we ask people to do, which is a how are you survey, and we've responding to that. And the important thing is that this is a system-based initiative. It's not just about the NHS Trust, although it is about the NHS Trust, but it's also about the parts of the system that are likely to have less refined, less developed services in occupational health, staff wellbeing and support, so particularly social care, primary care and the voluntary sector. So there's also the enhanced offer, which includes connecting groups for people in groups at different levels, and we really are focused on the first 2 or 3 levels of support. So so a self-help, self-refer kind of people who are interested in thinking about how they might support themselves and their teams, and then that more training and development and team support. And what we haven't included to date in our offer is the 3rd level, which is about individual support. I'll come on to that in a minute. It is intended to be complementary to local offerings and to what's being offered nationally. And it's open and accessible to anybody. And I think important to say, so it's a the Together in Mind website is an open website, and whilst we have lots of people from in North Central and North East London accessing it, we have people also from all over the country and all over the world. And if I can just give you a flavour, last week we had 459 people listening to our podcast, and 100 of those were people in the Ukraine listening to one single podcast about a 5-minute anxiety reduction kind of technique, which is really interesting. So the next steps with NCL in mind are going to be thinking about more in those 2 levels, but also thinking about one-to-one support for people who might need it. And we're currently working that through with the ICS. So I'll hand over to Lydia for the next slide.
Okay. Thanks, Chris. So could I have the next slide? But just wanted to say a little bit about how partly with an eye to thinking about what it was that meant that it has worked to the extent that it has. So what we've sort of learned through the process, and it's been very much set up on the basis that we are informed by ideas about the potential impact of potentially traumatized situations. We're assuming that everybody's traumatized, but the need for sort of watchful waiting and being ready to see how people are experiencing what they're exposed to from wherever they are in our organizations. So the website was set up with a survey for gathering feedback about how people are and what's on their minds and what kinds of resources they think would help. Then we've created content in response to that, or curated it and gathered it, because as you remember, there was an absolute flood of stuff coming through the internet, you know, from Uncle Tom Cobley and all about anything you could possibly want in relation to responses to COVID. So trying to stem the flow a bit. We've consistently asked for contributors from across organizations in health and social care, across the then SGP, now ICS, which has felt very important to be visibly doing that. The overall trends, people are really clearly, or certainly earlier on, I think it's still continuing, really clearly looking for things that feel doable and feel practical. And that's been quite marked. We had, for example, early on, 2 podcasts that went up on the same day. One was about recognizing signs of trauma, and the other was about dealing with them. And the dealing with them got a massive uptake, and the recognizing less so. So people are interested in doing, not so much at this point about thinking. Rest and time out, self-care being particularly reported areas of needs. But I think the bit we wanted to emphasize for the next step is that the collaboration and cross-system working was really important, even though it was quite challenging, because of course, as in all of these situations, it's hard to get away from ordinary competition. So just trying to get over that and work together. And also the idea of watchful waiting and the need to have provision that's sort of ready and accessible for the moment when it's needed, rather than going in and saying, well, we know you need this, getting into a position to say, well, we're waiting to see whether you need something that we can then quickly build an offer. So I think that's probably our 5 minutes, so I'll stop there.
Great, thank you so much. So we'll move across to our next speaker, who's Kate from Whittington Health. Don't forget to please put questions in the chat box and we'll pick up questions at the end. Thank you very much, both Lydia and Chris. Kate.
Hi everyone, I'm afraid I'm not going to be able to stay to the end because I have to go to another meeting, but if there are any questions then I'm happy for people to email me directly. So just to go through quite quickly, my presentation is around HR and OD support in a crisis. Like everybody, we had to come together very, very quickly and think about what we could do as a service while we were going through challenging and difficult times, and what we could do to support our staff. Right at the beginning, if we can remember that time, we didn't use Teams or Zoom or anything on any kind of regular basis whatsoever. So we actually did it, if you can believe it, face to face. So quite early on, we had a big meeting, probably not particularly socially distanced, but a big meeting about what support we could do. And we very quickly came up with the pyramid support scheme. And that was recognising that all staff need support, but that also there would be different levels of support that was needed. We tried to categorise that extremely quickly. Now, obviously, this developed and we put more stuff in as time went on, and we're in the recovery phase now of the pyramid scheme. But what we did was we actually worked very, very closely with our IAP service to provide support to all staff and then up the pyramid. Step one was our support programme for everybody. So the slide's gone a bit funny, but we can send it round. So that was things like drop-in programmes designed to promote wellbeing, and that developed on obviously to online programmes. 24-hour staff support helpline, which all HR and OD all manned together. We got an airport lounge, so we worked with airlines, and actually that's still going at the moment, where we provided free tea, coffee, breakout rooms, and that was actually put on by volunteers across the trust and also by pilots and air hostesses. So it's got nice music and things on it. We had targeted HRB line management supports, all staff emails like everybody, intranet guidance, and we worked very, very closely very early on with our staff side colleagues as well to provide a joint union and HR/OD support. Step two was psychological first aid teams and team leaders across the trust. So that was via our already in place mental health first aiders and via our IAPT, our targeted IAPT support. And we also developed that as we went on to include shielders and to include other networks, BAME network. Step three was specific support to hot area COVID teams, again with our mental health first aiders and our IAP team. Step four was stress management support to individual staff. So we publicised this and we gave details of where staff could go to have one-to-one support. And step five was evidence-based IAPT online treatments for staff with pre-existing mental health conditions. As part of our, sorry, I'm doing it really quickly, but I've only got 5 minutes. As part of our recovery phase and kind of our developmental phase, so I kind of think of that sort of as May onwards, we became probably like everybody. We've got a lot of networks, and I think we've really, we had networks before, but we've certainly understood, I think, the power of networks, both as an organisation and individually. So we've got our Wellbeing Leads network, and that has continued to monitor and support staff and how they cope, and we do temperature testing and quick staff surveys, etc. We've got our Shielders network and our Welcome Back phasing support programme now. We've got our BAME network, and we've also, we're piloting at the moment, but it's across London, just a specific HR BAME network as well, because we've got some feedback from our HR colleagues that they felt that they needed their own support within HR, because that can be quite difficult sometimes. getting that. So we've piloted that within the Whittington, and we're going out London wide. We've got our manager network. So and that actually started extremely early on. It was one of the first teams network meeting that we did. So that's to provide peer management support, and that is continuing. And we are continuing with our reflective practice sessions on an ongoing basis within our recovery programme and our CHP staff support service. We're utilising a lot of charity funds as well, so we continue with our airline, our airport lounge, which has been very well received by staff. That's it. Thank you.
Brilliant, Kate. Thank you so much. I think it's really helpful to see what you've done, and also the response from staff, particularly to things like using the airport lounge and other staff from other areas. So thank you very much.
Thank you. And I'm sorry I have to go. I'm a real flying visit for me.
Right. Okay, lovely. Thanks, Kate. I'm going to just talk a little bit now about the context of welfare support, both at Moorfields and also at Nightingale. Moorfields is an acute specialist trust which opened in 1805. Nightingale was an emergency response hospital that was built in 9 days. So I think across both Moorfields and Nightingale, we did very similar things to other UCLP trusts in terms of the welfare offer, and others on the call will be able to describe this. So I just wanted to put a bit of learning in around some of the organisational contexts that were different. So again, like Kate, today must be the day of the pyramid. I've used sort of Maslow's hierarchy of need as a lens just to think through some of the contextual differences between the welfare officer at Moorfields and that at Nightingale. I think, as we know, each level has to be satisfied before we can get to the alma mater, which is going to be self-actualisation and full development. And I think during the crisis, we saw a lot of return to real basic physiological needs having to be met. We particularly saw this at Nightingale in terms of the new setup. We had a staff helpline which was available 24 hours a day, and we had hundreds of calls in the early days, which was all around what my shift pattern was, where's my accommodation, what can I expect, what's my training. So a real focus on basic needs being met around rest, well-being, food and accommodation. And I think we also saw that at Moorfields, we had an advice line similar to other partners, but very much around advice about shielding, self-isolation, and how to interpret guidance. So the next level up on Maslow is around safety. And I think one of the differences was that Moorfields was a perceived safe environment that changed to an unsafe environment with COVID. So we had to think about how we put safety in, especially as the evidence from China, and it was an ophthalmologist who died that was the whistleblower. As an ophthalmologist, you spend time very close to patients on a slit lamp. So there was a real anxiety and concern about whether ophthalmology was at higher risk. I think in contrast to Nightingale, there was the ability to build safety into the onboarding and recruitment process and getting people into the organisation. So I think that was a sort of different contextual challenge, is how you make something safe that feels unsafe to something that is perceived as sort of a COVID hospital and build the safety into it. So going forward, I think the other areas that were different, at Moorfields, we went down from 25 sites to 8 sites. So we redeployed staff across those 8 sites, plus we redeployed them to other organisations. So there was quite a lot of team changes. Whereas at Nightingale, because of the 740 staff that were rostered, pretty much all of them came from a variety of backgrounds and came in new. So we formed new teams rather than have to sort of redesign existing teams and redeploy teams. What made a big difference at Moorfields was where we could redeploy one of the leaders with the teams that was redeployed. And I think leadership played a key role as well in terms of team management at Nightingale. At Moorfields, like others, we pulled together what existing support we had available and refocused that into providing staff support. Whereas at Nightingale, we had dedicated on-site occupational health, mental health, welfare teams, and particularly clinical leads for welfare and staff support. Recognition, I think one of the things that came out particularly from the exit interviews was around staff feeling at Nightingale that there was a flat structure and a flat hierarchy. And I think that was an intention by the leaders who set up Nightingale, and that was reflected. At Moorfields, we did a lot of recognition and thanks. Just can I go back to the learning slide, and we'll ignore the last slide. So the key learning, I think, was welfare was prioritised and mobilised at pace across all organisations. The sharing across the system and the support from regional and national. Onboarding and orientation is key. And then just one final point, face-to-face contact with psychological support rather than telephone or web-based, I think really made a difference, both at Nightingale but also at Moorfields. People accessed it in a different way when it was there. Right, my time is up, and as chair I've done appallingly, I think, in terms of managing my own time. So I'm happy to share the slides, which also have evidence from exit interviews and also more about the flat hierarchy, which really made a difference to staff in terms of self-esteem and self-actualisation. So thank you. I'm now going to hand over to Jo Cooke, who was one of our key clinical leads and somebody who I had the pleasure of working really closely with at Nightingale. Jo.
Thanks, Sandi. Next slide, please, Sophie. The Nightingale, as we all sort of know, was to support London and save as many lives as possible. But we had to do this safely and compassionately, and Sandi's sort of already touched a little bit on that. It just wasn't about chocolate bunnies and a comfy bed and hand cream, albeit that's quite important. But we were going to ask staff to work in an environment that was alien and high risk. So it was essential that we built safety and supported to everything that we did. And finally, for me, really, was more importantly, was maintaining humanity and personalisation. Next slide, please. People from the top to the bottom were very much our key assets, and that sort of was a deep vein throughout the whole of the Nightingale. Most people might excel in this environment, but some, would be broken. We were very, very aware of that. And we were very aware of the mental health challenges that would be heightened and risks of moral injury, where one feels unprepared and where actions or inactions would certainly challenge some of our sort of ethical code. And this was our biggest challenge, as we didn't know who was coming. We didn't know what their previous experiences or abilities, and they'd be working in environments that were out of their area of expertise. And we certainly saw evidence of it, but we found that people were questioning their competency and ability, and exacerbating that risk of moral injury. So we were really keen that we got it right, or as best we could. Our overall priority was to support staff and make a high-risk clinical model as safe as possible. And we did this by using task-based competencies and adapted SOPs, quick reference guides, coupled with a really quite excellent supportive education programme, which I know Bryn is going to talk about a little bit later. Next slide, please. So the Nightingale mental health programme was very much sort of a multi-layered process, with the induction starting off with the psychological PPE, and I'm not going to go into too much detail because I know Chloe is going to talk about that, but it's having those frank and honest reflections about whether it would be suitable. And then we encouraged staff very much to buddy up, and this was quite alien to a lot of people, so that we could really keep a watchful eye on each other and identify those early signs of distress. And having that sort of savvy conversation of how did the shift go when people came out of the doffing areas. So simple things, but really important things. We also had like Cape welfare walkers that were cabin crew colleagues, where they had a mixture of React mental health and trim training, so they could have that psychologically savvy conversation with people. And we sort of pre-position those at the mornings in the welcome areas and in the coffee areas. So the ethos was very much nip it in the bud. And of course we have mental health professionals on site as well, and as Sandi's already alluded to, having that face-to-face was really quite useful. So we generated mental health information really, really quickly, and you'll see some of the examples on the slide, through videos, newsletters, posters, and what we really liked was those little wallet cards where people could take stuff away. We said we did, which offered that two-way interaction, and that was extremely popular. And a new thing for me was the Improve Well app, which was an excellent engagement tool. And it was also a morale tracker. It gave staff an opportunity to have a voice, but more importantly, a voice that was listened to and acted upon. And those who did engage with the app, did simple things like, we need clocks in the clinical area. To one ICU doctor said that, you know, it's such a surreal environment with rows and rows and rows of beds. That was really, it was just like ventilating bodies. So we developed a What Matters to Me posters, which were placed with the beds, and we got all the information from our liaison teams. And, you know, what came out of it was the single most initiative in humanising what could have been a dehumanising process. So, you know, that worked very, very well. As somebody's already said, and you can see the poster on the slide, it's okay not to be okay. And for some reason, mental health was not a stigma at the Nightingale. You know, people were very open to talking about how they were feeling. And we tried to incorporate it into every activity. Access to physical stuff as well, like yoga and Pilates. And the other thing, and Sandi's mentioned it, is having HR representation, accommodation representation on site, so people say, look, I've got a problem with my pay. So it took away some of those anxieties. Next slide, please. So Nightingale was very much promoting visible and compassionate leadership, and we don't always see that, particularly in the military, that effective two-way communication. And it was critical that we involved our users to inform what needs to be changed at a really simple level, and then take our ideas and adapt them. Clinical forums in the afternoon. We broke down many of the traditional clinical roles, and everybody really had a voice. And a new role that we've spoken about on the UCH talks before was the bedside learning coordinator. And I can't really sell that enough, and it's something that I'm definitely going to be bringing back to my own trust, where we collect and record SIs and risks in the clinical arena, and you offer that immediate coordination and liaison. And it all went to create a sense of worth and belonging. And it was the first time that I'd ever seen quality and learning and risk actually working together, and working together very, very quickly. So in summary, although the Nightingale wasn't in operation for long, it did provide a really good blueprint for how we could rapidly sort of establish healthcare facilities in these sort of challenging environments in the past. And for me, the true measure of leadership was to confront and support the anxiety of people. And if I drew it down to one thing, it was all about kindness and supporting each other. Thank you.
Brilliant. Thank you so much, Jo. So kindness and support and how we look after people was absolutely crucial for all of us across our trust. I'd like to hand over to Bryn Baxendale to talk about human factors and day zero training as part of the importance of increasing safety as part of the training and onboarding process. So Bryn.
Thanks, Sandi. Hello, everyone. Next slide, please. Thank you. So, well, where did we start? Where did all this start? So my early introduction within the program was really around the education and training program, and the slide sort of describes a fairly traditional approach to how we try to identify what knowledge and skills are needed for staff and develop that such that they're able to work collaboratively together and effectively to both perform well as an individual but also as a team, and also to gain some satisfaction, I think, from the work that they're doing. Next slide, please. The problem is we know that healthcare in general is a pretty complex and uncomfortable place at times, and sometimes there are areas where we try and deliver ultra safe care. Sometimes there are times when we need to innovate and adapt to circumstances very, very quickly, which we've not encountered before. The majority of the time, though, we probably rely on staff to be able to adapt, and for the system in which we're working to be able to adapt to meet the needs of the hazards and the constraints being faced. And I think this is true in general, but in particular, I think Nightingale managed to deliver this in spades. Next slide. Thanks. So the way in which we originated from the education training program was then to start to look at the work system and the work design and the jobs being done, to take a more systems design approach to understand that better and to see how that might complement or enhance the education and training program, but also how it might enhance the way in which work was being done to benefit the staff who were being asked to work in those circumstances. Next slide, please. This slide's a bit of a handful, but this is a sort of a human factors model which we were using to illustrate actually how we took a view over on the left side of the work system, where in fact we have traditionally there's a lot of response looking at the person or the people in the middle of that circle and how they interact with one another to do work, but actually we know that staff and individuals have to interact also with a range of technologies and equipment and an environment that is different or challenging within an organisation that has its own climate, and with work that may need to be maybe different from that which they normally do, and the way in which they deliver that work and the outcomes of that work sometimes are visible very quickly, sometimes they take longer for those outcomes to become apparent. But you'll notice at the bottom, the human factors piece really seeks to understand adaptations that are being made and actually understand whether they're based on deficit-based adaptations of because harm has arisen or incidents have occurred, but also if they're asset-based adaptations where staff have lent their expertise and experience and dialogue and shared at the clinical forum, as we just heard, to understand and to improve the ways in which they're able to do their work and to feed that back in all of the time. Next slide, please. So this then, for the human factors piece, starts to look at those adaptations very carefully, and we were seeking to try and inform those areas where we wanted to standardize aspects of care or ways of working, and where protocols or guidelines might help both the work that's being done and also to help staff in terms of reducing the cognitive or the physical or the psychological demands that were being placed on them, and thereby giving them space and capability within the teams to actually be able to deal with circumstances which were perhaps unplanned or even unforeseen because of the nature of the environment and the work that we were asking them to deliver. Next slide, please. So one manifestation of this was to develop the Day Zero simulation intervention on top of the education program, which was really a sort of safety net event, which was intended for staff just prior to them being deployed into the clinical environment to take the knowledge and skills which they developed through the education program, but also to put that into context where they were able to see what that looked like in terms of the clinical workspace, the equipment, the paperwork, the layout of the environment in which they were going to be working, and to really help cement that in their minds to try and reduce, I guess, some of the stress or some of the impact of turning up to their first day and suddenly being exposed with that row of beds and patients and everything else. And so the Day Zero simulation was an attempt to bridge that gap and enhance the preparation of staff. Next slide. So that's our final slide, really, where we were seeking to, and managed in some circumstances at least, to, I think, bridge a human factors systems design approach with the approach taken to prepare and support staff and the ways in which they were working to develop that team of teams approach, actually, which we hear about, which really supports effective and adaptive working to often quite unique challenges and constraints and hazards. Thank you. That's it.
Great. Lovely. Thank you, Bryn. We're now going to hear a little bit more about preparation of staff as we hand over to Krishna and Chloe, who are going to talk about psychological PPE. So Krishna and Chloe.
Thanks, Sandi. So Chloe's going to be manning the chat functionality. So if anyone has any questions at all as we're going along, feel free to post them live. It's a great position to be talking at this stage as the joint wellbeing team leads. As Bryn mentioned, team of teams, and I think we were a little sub-team of our own within this infrastructure that the Nightingale had, that Sandi mentioned, where there was a flattened hierarchy. Joe mentioned there was compassionate leadership where well-being was prioritised, and we were a sub-team of a well-being stream that arrived at the Nightingale Hospital with the task of preparing an induction programme in 5 days for those that were being redeployed, and as well as preparing them for the clinical skills that they needed. We identified at that stage within the induction programme that there was an opportunity for innovation, where we could think about the psychological risk prior to exposure within the environment. And that's where the concept of psychological PPE was born, from lots of conversations within a multidisciplinary team, where we felt as though the physical risk of COVID was being mentioned and prepared for. And akin to that, we were trying to provide education and training where individuals were being prepared for the psychological risk. And for me personally, being a GP registrar who'd been redeployed to the Nightingale to be part of this team, it was really interesting because I'd spent a couple of months in the run up to COVID building up, listening to healthcare professionals, contacting myself as their named GP, and dealing with a lot of uncertainty. I was working as a peer supporter for fellow junior doctors within the St Helier VTS training scheme, and there was a lot of emotional exhaling that was happening. And at that time, the amazing support structures, the pyramid of support that was being put together wasn't 100% in place at that time. So we found that these skills of actually just being there for healthcare professionals, providing a space where they can be themselves, they can share their vulnerabilities, and that being facilitated in an astutely psychological way was key to the workshop that we developed. And as mentioned, it's not just recognizing the early signs of stress and the early challenges that are laying ahead, but then forming an action plan. What we found within our workshops, which we delivered to about 2,300 participants in the end, was that when the solutions come from the individual, rather than a didactic approach of offering them services, when they are equipped with the skills of self-care, of learning to develop over time, how to build up their own self-care skills as a continuum rather than doing it or not doing it. It was a lot more helpful, and it was a lot more easier for them to be able to prepare for the environment that was in the Nightingale. In terms of psychological distress, we were trying to approach it at an early stage where stress was anticipated, and because every staff member had received this workshop, it also had the benefit of having an analogy that was carried through in professional conversations within the clinical floor. Once the staff joined into the Nightingale, there was opportunities for that analogy of how's your psychological PPE being implemented within the buddy system that was mentioned. So if there's a breach in your physical PPE, your buddy would be supporting you in managing that and supporting you through that. And similarly, if there's a breach in your psychological PPE, we hope that because of the workshop, different members of staff were able to converse more openly about any breaches that may be going on for them emotionally. So that's where our sub-team of psychological PPE sat within the Nightingale training and induction program. We had very good qualitative feedback from the process that has been helpful. And Sandi's been conducting some exit interviews that we've seen some results from, which provisionally say that 82% of the Nightingale staff that had the exit interview took part in it felt psychologically prepared. And going forward, Rebecca asked me to just mention briefly about where do we go from here. So Chloe and I have felt very passionately about the values that we've been able to impart within these workshops about being able to look after ourselves first in order to help look after others better. And, being a junior doctor, I felt as though, although it's in the midst of a crisis that we've thought of how best to possibly support our staff, more generally speaking, as a GP, primary prevention before psychological distress occurs, if we are building our skills of resilience, our skills of self-care, and being able to be clinicians who are more introspective on a day-to-day basis, so that when we approach any other transitions in life, be that a job change or a new environment or other high stress environments that may come our way, we can feel as though we are adequately prepared to manage that uncertainty in a way that is bespoke to our individual psychological PPE. It was a really interesting opportunity for the induction program to be a space where this idea is introduced, this skill is introduced, and we're passionately trying to incorporate that into other healthcare environments through a more versatile version of psychological PPE, which is called Psych PPE. So yeah, this was what we did. We welcome any questions that you may have. And thank you for your time and listening.
Great, thanks Krishna, thanks Chloe. I think it's really important, and that the fact that there are so many staff now who've got that language and have gone back to their own organisations with that, I think is a real opportunity for hope. I'm going to hand over to John Jeans, our last speaker for today, and then we'll wrap up with the end of the session with questions and chat. So John, over to you.
Thank you very much, Sandi. I am a little bit conscious of time because so I'll just shorten my talk ever so slightly. The title of my section was Behaviours in Clinical and Non-Clinical Teams. And I thought quite a lot about how best to articulate the experience that I've had over COVID and working with a range of different colleagues in a range of different environments. And the best way that I could surmise it is to use the words of someone who has a lot more experience and knowledge than I do when it comes to organizational development, a lady called Sue Rubenstein. And she says this maxim, which I think is really important, and it's a great way to think about life. Culture equals behavior. And if we think about every single behavior and how we stack up all of our individual behaviors on top of each other, that describes or defines and creates a culture. One of the most interesting things about working in the Nightingale Hospital and the environment surrounding it within the education and training team, but also working across the floor with a range of different clinical and non-clinical colleagues, was the high quality behaviors that were observed almost universally and almost all the time. I say almost all the time because nothing in life is perfect, but broadly, there was a really high desire to engender and display good behaviors, and that then clearly fed on to a wider community of practice that was able to deliver some very impressive outcomes within a short space of time. In terms of how those behaviors were held, I think there's two ways to think about driving behaviors that can create a good culture. One of them is the structures that you put in place that engender a set of behaviors, and two is about the behaviors that people model when they speak and interact they speak, write, and interact with each other. In terms of how that was manifest within the Nightingale, we've already had a range of very strong examples from a range of different speakers here, and I'm sure that everyone on the call will have seen some very, very impressive outcomes during the COVID response. In terms of what the experience that I saw, with regard to creating the right set of behaviors, it was great to be able to work with a team and a team of teams that were all very, very keen to give good examples of behaviors and to take appropriate feedback and give appropriate feedback about how those behaviors could be improved. The other thing that was very interesting was about the structure that was deployed. As everyone has alluded to, it was a flat structure, and that flat structure was delivered in various different ways. I would say flat, shallow structure was delivered in various different ways across the different disciplines. Within the education and training discipline, we were very conscious that we needed to display good behaviors and have a flexible structure, given that the needs of the other parts of the organization were going to adapt and to change. And so this was, and we were also very conscious of the need to have good behaviors and good interactions because we were the first physical point of contact for many different disciplines as they came to work into the Nightingale Hospital. There are a range of different ways this was done. Psychological PPE by Chloe and Krishna was a great asset, but there was also various debriefs throughout the education process, and then there was the learning and feedback loops that were led by the BLC role, but then integrated into the wider learning system and fed back through a daily big room meeting within that aligned all the clinical and operational groups in one area, so that changes could be rapidly made and implemented. I am a little bit conscious of time, so I am going to sort of draw it to a close here. I had some more to say, but the key learning that I would take away from the experience is that culture truly does equal behavior. And if we can all think a little bit about how we interact with each other and how we model ourselves and set up structures so that we can support the good behaviour and the right behaviour within our colleagues to manage a range of different situations. That will enable us to adapt and improve as we go through the recovery period with COVID, to ensure that we can give our patients the best possible care over the coming 18 months in the NHS and social care.
Great. John, thank you so much for that. And apologies for having to cut you short. I'm sure there'll be other opportunities where we can sort of go into this in a bit more depth. So thank you for that. So what I'd like to do now is invite any questions that anybody on the webinar may have that we can then direct. And I will be looking for a bit of help. Because I'm on a phone. Let me just have a look. Okay, right. Nazia, to everyone, where can we learn a bit more about the bedside learning coordinator, please?
I'll write down a colleague of mine's email, Jenny Shand, and you can also contact John about the bedside learning coordinator role. So I can put you in touch.
Can I just say as well, we our first session focused a little bit on the bedside learning coordinator, and you can access that session through our website. So if you are interested, do go and have a look. I can circulate a link to the recording of the first session if people are interested.
Thanks, Nazia. Other questions? Great. Okay. No other questions, observations, comments, feedback? Great. Okay. So having shortened John, we've now got a little bit of time. So I would want to say thank you so much to all of our speakers. I think it's been amazing to have such a different range of input, but all that sort of pick up on the wider contextual things, and also the importance of sort of culture and environment and how we manage wellbeing as well. So thank you so much. I think every speaker was distinct and had their own area, but the themes that came out of this are much bigger than the individual contributions. I don't know if anybody else feels like that, but I can see, Chloe, you're nodding. So thank you so much. And I'll hand back to Sophie and Rebecca.